Everyone's eyes have been opened to the pandemic's effects of trauma. Now everybody is struggling from the predictable aftermaths in what we would call trauma-driven or trauma-related mental illness, substance use, suicide, and overdoses, especially and tragically in young people, in teens and young adults.
Dear Family is a podcast hosted by Rachel Steinman, a writer, an educator, and a mental health advocate. And Rachel gets us up close and personal, so we feel a strong connection, familiarity, and comfort with her guests. So settle in and join us as we search for true healing and journey with Rachel and her most interesting guests.
Hello, everyone, and welcome to another episode of Dear Family, the podcast. It's hard to believe that this is already episode number 96. Thank you so much for listening and joining me on this journey to discuss our mental health and make it a priority. That's what this episode is all about. I don't know about you. Maybe it's because I have teenagers, but the topic of mental health is a big one right now among their peers, and it's being talked about at school, and so much has changed since the pandemic. And Dr. Jonathan Goldfinger, who is here today to talk about it, is giving me a lot of hope. But we still have a long way to go. He is just so incredibly informed, and I'm so impressed with all he is doing to help so many families and individuals and adults and teens and kids. And I know you're going to learn a lot. So thank you again for listening. Thank you for subscribing to this podcast and following me on all the social media platforms. That's Right Now Rachel, right with a W. If you felt like giving me a great 5-star review, that would be incredibly appreciated. I'm so grateful that you're here listening. I wish you all the love, all the happiness. I hope you get outside and enjoy this beautiful spring weather. Take care, everyone. Thanks for listening. Dr. Jonathan Goldfinger is a nationally recognized pediatrician and an advocate for mental health services for children and families, including in minority and low-income communities. His inclusive approach to health equity and policy have transformed countless lives. He joined Didi Hirsch Mental Health Services, an 80-year organization, as the CEO just months after the pandemic began in June 2020. Didi Hirsch is a national leader offering free mental health, substance use disorder, and suicide prevention services. They're pioneers in specialized therapy and support groups for children and adults and families, while also offering crisis residential facilities. Dr. Goldfinger's personal connection to Didi Hirsch's mission stems from his own intergenerational trauma, including behavioral health challenges in family and friends, experienced from a young age. With the support of nurturing grandparents and parents and other adults, he developed strength and resilience that gave him hope and a desire to help others by combating structural stigma, poverty, and racism. With a BA in philosophy from Columbia University, Dr. Goldfinger completed his MD and MPH, that's Master's in Public Health, at Mount Sinai School of Medicine, and he did his residency and fellowships at Children's Hospital Los Angeles. He brings his expertise in intergenerational trauma, integrated care, and health technologies into a more humane, team-based digital age. As Chief Medical Officer and Vice President of Innovation at Center for Youth Wellness, he oversaw national and statewide collaborations and research addressing childhood trauma, including parent mental illness and substance use, child abuse, domestic violence, and discrimination. Before that, as Chief Medical Officer at 0 to 3, he led a national office to scale Healthy Steps, integrating behavioral health and primary care for parents and young children through transformative partnerships with health systems, communities, government, and philanthropy. Dr. Goldfinger currently serves on the California State of the Surgeon General and Department of Healthcare Services Trauma-Informed Primary Care Advisory Committee. He's published with the CDC, among other publications, and he's won numerous awards and honors for his advocacy and public health research. Dr. Goldfinger lives with his accomplished and beloved wife and their 2 adorable boys. Welcome, Dr. Goldfinger. Nancy Hirsch Reuben, the daughter of Didi Hirsch and a huge mental health advocate in her own right, told me that I had to have you on the Dear Family podcast because she said that you're a dynamic millennial voice in this field and you're triumphant in your professional achievements and you're providing help for so many people. I was really honored that she made the introduction, and I'm really grateful to have you on today. Thank you for being here.
Thank you. I appreciate being here. I hope I can live up to Nancy's accolades.
She's an amazing woman. Why don't we start out by you telling us a little bit about yourself and a little bit about your family?
My name is Jonathan Goldfinger, and I'm a pediatrician and public health professional who's spent most of his career advocating for the integration of mental health services into healthcare and really at its core, access to mental health care for children and families and increasingly teens and young adults and even now older adults. And during the pandemic, I became the CEO of Didi Hirsch, one of the nation's original community mental health centers, and today one of the national leaders in crisis care and mental health services. And my family includes a wonderful wife without whom I could not have achieved any of these things in my life to be able to really serve others, who is a pretty prominent attorney at a local museum, and two beautiful boys, a 7-year-old and a 4-year-old, keep us on our toes.
Well, that's the best age. I used to teach kindergarten and first grade, so enjoy them. They're gems, the things that come out of their mouth. Take lots of video. You'll be happy about it.
That's so funny. I actually got my start teaching in Manhattan. I was teaching Hebrew in kindergarten and first grade. That's one of my first jobs in college and right after college.
I love that. So you're also an educator. Do you have any personal stories in relation to mental health?
Many. Where to begin? I often share that I became a trauma researcher, particularly around intergenerational trauma, having lived through as a young person, as a child and even teenager, a household where there were certainly adults who'd experienced tremendous adversity themselves as children. My father is the son of Holocaust survivors who lost their whole family to the Nazis, and how that affected him, how that affected his relationships. Even as a very successful person and individual in the home, it certainly had repercussions, and there were others in our family who had similar experiences, similarly difficult or tragic experiences early in life. And so I became that researcher myself, a child of adversity, and found myself even in my youth, young adulthood, kind of having those pretty normal ups and downs of life struggles, whether it was going through medical school or a very difficult breakup. And at times found myself, I wasn't sure, am I on the cusp of depression or anxiety, or is this life? And the truth is, both are true. And I thankfully was able to get help when I needed it, to take the time to care for myself, as well as trying to prepare for a career helping others. And in my journey, also realized how much of that was due to my childhood long after, and my childhood and my family. I'm grateful to those along the journey, researchers, advocates, educators who were there for me early on, safe, stable, nurturing adults to buffer the what we call toxic stress of my environment, which really enables the resiliency I'm grateful for today in the hard work of bringing mental health care to children, adults, and families across Los Angeles County in the United States. And also to the ones more recently in my career who helped me see how I ended up on this path.
I also am interested in intergenerational trauma. I come from a family with a lot of mental health disorders, and I wanted to address it and be able to talk about it and not pass it on to my daughters. What you're doing is you're trying to cut that generational trauma, not just for yourself, but for others. And we do that by talking about it. That's the beginning. And that's what we're doing right now. You got your Bachelor's of Arts in philosophy from Columbia University. And then you went on to medical school at Mount Sinai. And before that, you were teaching. But you did your residency at Children's Hospital, LA. So what made you go from being a philosophy major and teaching to decide to work in the medical field with children?
It's a great question. It was actually working with teenagers in Harlem while I was at Columbia, supporting them as a mentor and a tutor as part of a program. We called it Project Health back then. Today it's known as Health Leads, where students on privileged college campuses can go into inner city neighborhoods and really become advocates within healthcare for what we now refer to as health equity. But back then, we were advocating for these kids in Harlem to get the most basic pain management for their sickle cell crises. And we knew in our hearts that they did not get it because they were Black. And the fact that we were white enabled us to even be there and have a say, when really that should have been their say that counted. And years later, I realized it had probably been about 10 years between the time I was advocating for these kids in the emergency rooms in Harlem Hospital to my residency. And we were still facing the same thing, only this time I was on the other side. I was the health professional and the colleague. And one of my mentors, attendings, really laced into a trainee for what he perceived to be a bias in terms of how we feel about Black individuals, including kids, and their pain tolerance or threshold and our treatment of them. And so I would say the theme, the journey that brought me through all of it was a journey of social justice, health equity, understanding that there remain forms of discrimination in society, racism being a critical scourge, but others that we really have not uprooted, even in some of our most venerated areas like healthcare. And that remains today. I wanted to help people from the outset address these issues, and I realized I could probably help them from the inside. And I got my public health degree because I found myself gravitating toward those systemic changes and what I could do to bring data to inspire my colleagues, inspire decision makers at the level of government, philanthropy, health systems design, to really make a change and say we're going to pay for a certain kind of quality, a quality that focuses on universal access, cultural competency, and really creating services for and by communities or populations that previously were not even at the table. Today we have them at the table. And now the question is, do we understand that we're still in this position of privilege, and how do we utilize that to give them the right to healthcare and mental health care, especially today, as people recognize that they so desperately need and deserve.
You served as Chief Medical Officer and Vice President of Innovation at the Center for Youth Wellness in San Francisco. And you spearheaded the national effort to address adverse childhood experiences such as abuse, parental mental illness, and discrimination. And now you are the CEO of Didi Hirsch, and it seems like a very great fit. Tell us about the incredible services that Didi Hirsch offers and what your day-to-day role is.
Thank you. It does feel like I joined just about the most incredible organization at a crucial moment in time when everyone's eyes have been opened to the effects of the pandemic's effects of trauma, especially trauma in young people and children and our families, to the many stressors on ourselves, on our own mental health, our own substance use, drinking, in the case of young parents, being a critical risk factor for child abuse and neglect. And these are not just physical abuse. This includes emotional abuse. Are we speaking to our children as kindly as we might, or do we find ourselves shouting more than usual? And this is a critical moment of awareness in American history, where not only are we aware of the systemic inequities and in access to care that more frequent or disproportionate deaths to the COVID-19 virus in Black and Latinx communities raised the public consciousness of. But now everybody is struggling from the predictable aftermaths and what we would call trauma-driven or trauma-related mental illness, substance use, suicide, and overdoses, especially and tragically in young people, in teens and young adults. I come to this moment as the chief executive officer of an organization that has the full array of mental health, substance use, and suicide prevention services. Didi Hirsch is an 80-year-old organization that is now a national leader in whole person mental health and crisis care. We are the largest provider on the National Suicide Prevention Lifeline, a 1-800 number, soon to become an easy-to-remember 3-digit number, 988. We are experts and have been pioneers in suicide-specialized therapy and support groups for children, adults, and families. We have incredible outpatient mental health therapy, treatment, medication management, addiction, substance use treatment of all kinds. And we also have crisis residential facilities, 3 facilities, 2 where adult males can go and heal from substance use and mental health disorders, and 1 where women can go either pregnant or with their babies and toddlers in tow. That keeps them out of the re-traumatizing child welfare system and halts that intergenerational trauma we're talking about. Didi Hirsch is really a premier mental health and crisis care system and really a model for how America could do it better. And I'm so honored and proud to be at the helm of this incredible institution right now when people need us.
It's really true. The fact that it was started 80 years ago, no one talked about suicide then. People were dying by suicide, but it wasn't discussed. I agree with you. It does feel like this incredible moment where people are really talking about this. And speaking of that, you currently serve on the California Office of the Surgeon General and Department of Healthcare Services Trauma-Informed Primary Care Advisory Committee, among other organizations. And you've published with the CDC and you're traveling to DC. What are you advocating for at this moment?
In this window of opportunity where the President of the United States is talking about full parity between mental and physical health, for your listeners, that basically means that we shouldn't pay for any less frequent care for mental health services than we do for physical health services. Nearly 100% of people can see a doctor when they are physically ill, whether it's urgent care or primary care. But only 40% of people, including teenagers, kids, can see a mental health provider when they need it. And if it's for a substance use need, it's only 10%. If it's for a suicide or crisis, mental health crisis need, only about 10% can access care. That means 90% of suicidal people have no professional help. I would say the 2 key things that I'm advocating for is the first, we've been grateful to secure about $20 million from the Newsom administration, which we signed the contract the other day, and an additional 12 plus more from Federal Substance Abuse and Mental Health Services Agency, known as SAMHSA, through Vibrant Emotional Health, to scale 988, essentially 24/7 English and Spanish crisis care and supports through calls, chats, and texts. We're on our journey to scale for that as the 988 number launches in July. So now we have a lot of the money and there's even more coming from the federal government. But what we need to do is start to create the models for sustainability. So I'm really advocating that we don't make one-time government investments and pat ourselves on the back. Yes, we're going to save so many lives, but we need to do so recognizing that 988 is telehealth. This is a form of healthcare, and a lot of the narrative that you hear is this is an alternative to 911. A narrative that we've helped because Didi Hirsch also recently pioneered a model where we're working closely with the LAPD so they can transfer callers to Didi Hirsch so the officer never has to arrive. So clearly, we need to be working closely with 911, but I'm really advocating in DC and anywhere policymakers will listen and health insurers will listen that 988 is not an alternative to 911 For the person calling it is, but we're not the operator who picks up and on average triages the call within 20 seconds. We're the ambulance. We show up, but within 20 minutes on average, we can save your life. We're just that good that we can do it over calls, chats, and texts. So that's the first thing. Advocating 988 is telehealth, and this is a wonderful opportunity to ensure that federal mental health equity and parity law are enforced, not just through taxation, which is what was in the bipartisan bill for 988 signed by Congress, but through health insurers paying their fair share, whether it's Optum, Blue Cross, Blue Shield plan, Anthem, not to call anyone out, or a local Medicaid plan, Medi-Cal in the state of California, LA Care, HealthNet, or even county plans. It should not matter. They should all pay their fair share, whereas today it's only the more specialized, expensive system of healthcare financing in our counties and our state government that are paying for it. That should not be. It's not equitable, and it's not going to lead to the best outcomes for the most possible people. That's why we only have 10% of lives served. The other thing I'm advocating for is to enforce writ large federal mental health equity and parity law. It's amazing that insurance companies can get away with paying so little and for so few visits for mental health care. Today is the moment that we need all citizens to demand that of their employers. That's usually where most people get their health insurance. Demand it of your employer. Say, I'm not going to come work with you or for you in this great resignation period where we have options unless you make mental health a key benefit, a work perk, including the work environment. But at a minimum, my child, my family, my parents, my community need to have access to excellent mental health care, and employers, insurers need to pay for that. So I'm advocating our states, our federal lawmakers consistently hold a candle to what insurers are doing when they deny claims, like we once did for pre-existing conditions like cancer, heart disease, things that can be devastating but do not go away in a heartbeat. We need to do the exact same thing for mental illnesses. These are just brain diseases. It's unconscionable that businesses like health insurers and even government-led payers would use excuses they use, as I unfortunately see day in and day out, to avoid paying for these types of diseases.
And also, when you have good mental health, it leads to better physical health. So they'll save there as well. It's mind-bending to think about how most psychiatrists don't even accept insurance. And then if you do go, getting a good one's maybe $500 for a visit. And then these therapists are like $200 a visit. People can't afford that. Even before the pandemic, kids coming in with mental health crises is skyrocketing. I'm curious if you think that kids are being overprescribed anti-anxiety medications, antidepressants, SSRIs, ADHD medications, or do you think maybe they're finally being properly diagnosed?
I believe it's actually a combination of both. When you have any industry like the pharmaceutical industry, which is a critical partner in this space, we really do need better medications and faster and other forms of, let's call them biologic treatments. And you need investment in that. We really do want pharmaceuticals and other biotech invested in and partners in this space. But when you have an industry whose driver is financial, obviously their goal is to sell drugs. So they're going to influence, and the data is absolutely clear, the pharmaceutical industry hasn't been influencing physician prescribing since the beginning of the pharmaceutical industry, whether it's an attractive person showing up in my office or an attractive golf trip or lunch. Even when I was in residency, one of the things we decried was lunches paid for by formula companies when we were advocating that mothers breastfeed. So this is rampant. This is everywhere. And if we turn a blind eye and act like it's just a lunch, what's the big deal, John? Well, the big deal is that humans usually don't realize when they're manipulated. That's the point. They don't realize the behavioral science that goes into affecting our purchasing decisions. Now with social media, people are kind of realize, oh, look at that ad, or how did I go on my web browser and all of a sudden Google is telling me about something I just bought somewhere in a store. This odd AI data-driven big brother watching us, manipulating our behaviors. People are just beginning to recognize it. And I'm grateful, at least in the social media realm, for the folks who put out the social dilemma, and now for Congress for taking up the mantle, and even the president for holding social media accountable for this manipulation. But social media didn't invent this. Big business invented this. This is a modern version of what we've known. Pharmaceutical companies do a lot to educate providers, but they have the incentives. Maybe it's cynical, but I assume at this point that they really are getting, by intention, us to prescribe. Now, that doesn't mean people don't need the prescription. It's a question of how frequent, in what volume, and certainly we've seen with the opioid epidemic that this can run amok, and we've done a wonderful job in the United States at curbing prescribing. Give my physician colleagues props, public health colleagues. We really have curbed physician-driven prescribing, so much so that the opioid epidemic is largely driven by illegal fentanyl, the illegal illicit fentanyl market, which is the drug trade. That's not as much healthcare's fault anymore. But I believe, yes, we've been influenced, and how much we are today versus how much are we really reforming and refining our systems, especially for the child pharmacologics that you mentioned, is a good question. It's not my area of expertise, but I believe that we are improving. And I'll just say that, lastly, the fact that we don't also have therapists, resources, clinical interventions that are not a drug, in some ways enables or allows well-meaning physicians, including myself, at times when I was seeing kids, if I can't get them into therapy and they're getting into fights at school or threatening violence to other members of their family or unable to do their homework and succeed, am I going to give them a little dose of an ADHD med, which is kind of the equivalent to coffee? We've all been there, struggling with our thoughts, not exactly crystal clear, sharp in a meeting. I could give that little bit to that kid while they wait for therapy, even if I know, as the data constantly shows, it's not meds or therapy that helps on their own. Usually it's a combination, because these are both biological and sociological issues at play. I understand why my colleagues, and certainly at Didi Hirsch, why we prescribe certain things, because that's really the benevolent thing to do, even as we advocate to get people into therapy. Now, in our case, we have both operating at the same time. And even we, one of the most mature mental health systems in America, even we, I would say, are still working on what does that seamless integration of care look like between a prescription, medical care, and therapy, more traditional mental health care. And that's an important journey with our clients and those we serve to really be on, because people evolve, systems evolve, financing, as we discussed, evolves. And we need to be at the forefront of that. It's an ongoing effort at Didi Hirsch. It's an ongoing effort throughout healthcare. And I'm hopeful that integrated care models and certainly controls on pharmaceutical advertising and prescribing are working.
Absolutely. We need to have those support systems for our kids so they don't fall through the cracks. Thankfully, there is a place like Didi Hirsch. I'm curious what your thoughts are on the access to teens vaping, whether it's vaping marijuana or vaping nicotine. And it's so easily accessible. If you walk into a weed store, everything's geared towards kids. I'm wondering if you have any thoughts.
I do. In fact, my wife and I passed by one right in our neighborhood the other day and just thought, what is this messaging to my child? It's a bunny rabbit on the logo, and my child noticed it. So both personally and professionally, I feel very strongly, unlike the pharmaceutical industry, where you can give justifications, the tobacco industry cannot give any justification for their marketing and their efforts in this way. And it's really pervasive. It's at the origins. If you remember the CEOs of the tobacco industry straight up lying to Congress, straight up lying about their research. Sadly, we're hearing a little bit echoes of that in the social media arena with a recent heroic whistleblower. But the tobacco industry, this is an industry that at its origins clearly has targeted young people forever. I mean, Joe Camel, remember that?
Of course.
This is an industry that made smoking sexy for teens from its beginnings, because they knew psychologically that's when you had the stress, that's when you needed the hit. And now it's just found other ways through vaping. The black box warnings have done a wonderful job, and certainly screening for tobacco use where we identify it in practice as medical professionals has made a big difference, counseling on smoking. But industries that are designed to harm people and make money have no scruples. So they will find a way. Their shareholders want a return. I think it's on all of us to say, both from a legal and public health perspective and community perspective, this is unacceptable, to not be led into a state of false security that big tobacco is dead. It is not. It is alive and well in your neighborhood with a bunny rabbit on its logo. And I think we have to continue to advocate. The other thing that I would say is perhaps a different and concerning driver that has not been addressed, which is the mental health and trauma of these kids. The drive to smoke or vape is based on what's happening to these kids and where they are not accessing safe, stable, nurturing adults. So the isolation of the pandemic, coupled with increases in adverse childhood experiences, abuse, neglect of all kinds, and other mental health substance use challenges, plus the racial trauma of watching George Floyd's murder and the reckoning, raising more of it on the news. Thankfully, the body cams are there, but they're there for adults, but the kids see it too, right? And so this trauma and the rise in mental health, essentially anxiety, PTSD, and other trauma symptoms, depression even, these are driving kids to look for a substance. So we need to ask ourselves, why are they looking for a substance, and what can we do in the first place to mitigate the toxic stress on their brains of trauma to ensure that we have universal early care and education through trauma-informed schools, mental health care in schools. This, I would say, California continues to lead the nation in that our state is investing as much as I've ever seen in children and youth behavioral health from the earliest days, perinatal, maternity care, access to doulas. Doulas are the mental health support of the mother, so she continues through the birth, not in the traumatized fashion that most women describe childbirth as in research, through to the early childhood supports, through to school, through to counseling, through to colleges, and even into the workplace. All of this is going to come together to create a more caring, nurturing, safe, stable family and community around all of us. And that's really the foundational piece of preventing the effects of trauma, mitigating the risk that they have mental health challenges that then lead to them to seek out vaping. So if we get rid of essentially the market for vaping in that way, we can undermine big tobacco in a way they realize is coming, but they have no way of influencing.
I think teens are attracted to vaping because they think that parents can't smell it or they can do it anywhere. And they can access it through Snapchat. There's many ways for them to access it. They don't have to be 21 to walk into one of these stores. We're going to go back in time to the 1960s when there was a massive reduction in psychiatric hospital beds, and it was often referred to as deinstitutionalization. And the intention was to replace the psychiatric hospitals with community-based mental health resources. So good intentions. We'll cut to 60 years later, and we're in a huge mental health crisis that followed the pandemic, and people can't find hospital beds. And I heard a statistic that was so upsetting to me that suicide attempts among teenage girls soared to an increase of 50% in the first year of the pandemic. And so getting help is even harder now with wait lists, and there aren't enough psychiatrists. I know this is such a huge question, but what can be done to reverse this healthcare situation so that it's humane, team-based in this digital age?
The beginning step for advocates like myself, people trying to reform a healthcare system that was largely complicit in making any form of mental health or substance use less than in our system, is really to acknowledge, much like any form of systemic or structural discrimination or bias, to really acknowledge that history. For 400 years, since Descartes. People have been believing that the mind is outside the body, floating around. This couldn't be farther from the truth. We still haven't mapped every neurological connection in the brain, and we know there are billions. It's like the wiring in your house, right? Where did that sound come from, that speaker? Oh, I don't know. You can find a few wires and you're good. The sound, the voice in people's head, billions and billions of connections that could lead to that. But clearly they're there. There's no question about that. And they are disproportionately pruned in unhealthy ways with childhood trauma. It's not about what are the people with mental illness doing. It's about what happened to themselves, what happened to them early on that led to this wiring challenge. But the system is not set up to give them care. And I would say that along with those deinstitutionalization, which is still a goal, but along with it came what I call structural forms of stigma, or essentially discrimination, where we decided that, at least in California, and I understand to be across the country this way, mental health care would be paid for by government instead of insurers. Now, if you have psychiatric wards, psych facilities that no one wants to own on the nonprofit or the private side, because it's a very difficult, costly business, no insurance company wants to pay for it, I understand back then why government took it over. In California, we call this the carve-out, where those with moderate to severe mental illness, their mental health care is paid for by our counties, tax dollars and Medicaid dollars. That doesn't make any sense. We have a whole healthcare system. We talk about its costs. We also talk about its incredible innovation, the things that it can do. But it does that with cash flow that comes from healthy, somewhat capitalist-based economics of health insurers that are not governments. I'm not a huge fan of single-payer systems that do away with the private sector. The private sector has given us incredible benchmarks and innovations. So why that happened years ago with the carve-out is what it is. But today we need to acknowledge that our local governments essentially have too much power over who gets mental health care. And thankfully, the Newsom administration is addressing this in an initiative we call CalAIM, where we are little by little transitioning aspects of healthcare payment to tried and true health insurers away from county governments who basically just want to pay Didi Hirsch what we call at cost. For your listeners, as an example, I joined Didi Hirsch in July of 2020, right in the thick of the pandemic. And I looked at the last data on our fiscal year, and I saw this financial tank in revenue and service delivery, basically just a hockey stick in the wrong direction toward the end of the last fiscal year. And I asked our leadership, what's that? They said, oh, don't you know, in this arena, when we do a good job, and we went virtual, so in telehealth, we were able to serve more people faster. We have to slow down. We have to furlough our staff so we don't provide too much care to too many people. Imagine if you went to your primary care doctor, your pediatrician, and said, sorry, it's 2 p.m. We did such a good job helping people. We're closed for the rest of the day. We can't get paid anymore. That is mental health care in America. That's mental health care the way Didi Hirsch is essentially within a system where government controls and says, here's how much money you got, no more, no less. No financial incentive for quality. Trying to work on that with LA County, but very little financial incentive for the excellent quality that we provide, and no cash flow for healthy efficiencies, cost cutting, and excellent care. So there's no incentive to grow care. In fact, there's a disincentive to offer people more care the way governments pay for healthcare. So we have to get health insurers to pay for it too, so the government doesn't feel on the hook. But then we have to get the government and all of its elected officials to relinquish control of that system and recognize there's a healthier, better system for people to get care outside of government insurers. We clearly don't want people to be hospitalized. And if we were to do that and the services were made available through healthy and essentially fair and equitable payment of mental health care, you wouldn't have these little girls in the emergency rooms like that. And yeah, some people do need to be hospitalized, but the data still shows that people are healthier with services in family and in community. So we don't want to get rid of that. We want to augment what the community can do. And this is something that we focus on a lot at Didi Hirsch, which is services for teens by teens through a partnership we have with LA's Teen Line and other services we provide, so that peers can help, not licensed professionals, but there's a role for people with lived experience to be there as a support that they got through it. And here's how they navigated the system. And here's how they navigated that symptom, that side effect, that discrimination in the system. So the peer movement is a key part of healing in community. And we're grateful Los Angeles County is also a leader in this. And we continue to partner on models like that. There's a lot of work to do from those decisions of the 60s, but at least now our mindset is in the right place about where people belong. And if we align the dollars and we advocate, mental health is health, foundational to health, then we will pay for it adequately and properly. And a lot of people will not have to end up in the emergency room.
What DD Hirsch is doing with the peer-to-peer education is so important, especially among teens, because then they're more likely to reach out and not worry, because at that age, they're so concerned about talking or sharing. And I love that Didi Hirsch does the suicide prevention training. It's so important. Speaking of teens, the pandemic has really wreaked havoc on their mental health because they were isolated. They're meant to be social creatures, and not to mention social media, the fire hose that never gets shut off. It's that constant fight or flight, and they're not out there exercising potentially. Do you have any thoughts on the effects of social media when it comes to the increase in suicide and mental health?
I sure do. I think the data is now very clear that excessive use of social media, and there's no definition of that, but excessive use of social media is associated with mental illness and eating disorders and other harmful effects. Whether it directly leads to suicide or these illnesses are part of it and how people experience not getting care or worsening trauma. If you go on some of these platforms and you talk about an eating disorder, for example, one of the critical illnesses that social media fuels, three things will happen. One, no pun intended, you'll be fed additional resources and content that drives disordered eating, does not drive healing. So we know the system is designed to worsen unhealthy behaviors. In fact, negative posts in general get more likes, shares, engagement than positive posts. That's not just human nature. That's social media companies manipulating human nature because they know it's true about humans. Who doesn't like a juicy story compared to a really positive story? We just gravitate toward that. That's in our nature. So you'll get negative behavior and unhealthy, essentially illness reinforcing content. The other thing that happens is you'll get bullied by people who will tell you to continue to binge or purge, continue to treat yourself this way. Live humans. And how did they get on your feed? Because the social media company has designed it so that they find you. And then the third thing that happens is really what doesn't happen. You don't get access to any help. We have been part of a group called the Mental Health Coalition, led by Kenneth Cole, that partnered with Facebook to try to at least provide some resources. Now, Meta, this is before the whistleblower. But even then, Ken and I had a heart-to-heart, and I said, are we just giving them cover for what they're doing? Are we just creating a list? Now, as a physician, I know the research shows when I give patients in my clinic a list of something, they throw it out. They walk out, it goes in the trash, or they lose it. That never really worked. So I did question the use of a list. Is it because it's a list online, all of a sudden people are going to use it? I don't know. But more importantly, is this a substantive interaction, or is this hopefully the first, as we're thinking of it, interaction with social media companies where we're not just providing lists as PR moves, essentially, right? What we're doing is partnering so that we can look at the algorithms and say, why is this algorithm doubling down on your unhealthy behavior? Why is it getting hecklers into your feed? Why is it not offering care? And so I'm grateful that people like Ken will work with social media companies, and the work is still ongoing. And interestingly, Google just published, they call it MUM, and I forget what it stands for, MUM. You can probably Google MUM for suicide prevention. And this is going to get a lot of press, thankfully, where Google has learned through AI to limit harmful content when the search is about suicide and drive toward crisis lines and other services that can save a life. And if all social media companies are called upon to do this, and I mean called upon by citizens, by Congress, by the President of the United States, and held accountable if they don't, should be a carrot and a stick. They can do it. There's no question they can do it. They need to have the political will and hopefully the financial will. We should financially incentivize social media companies that have better health outcomes, and Didi Hirsch will be right there to partner with them to prove it if they come to the table and are willing to work with us rather than against us in one area of the company, while some of them are saying, yeah, we want to work with you. We're 24/7 on the crisis lines. We also need to be 24/7 providing crisis care on social media. That's another critical point of advocacy that I've been asking Congress and others to support. No reason we couldn't go on there in real time and help that young girl with the eating disorder so she doesn't end up in the ER after a suicide attempt.
As a parent, it's really, really hard to monitor, especially over the past few years with the pandemic, because this was how they were communicating with friends. And now when they're in school, they're on a laptop. And unless a teacher's standing over their specific laptop, they can't monitor. And even if they take a cell phone away, they still have their monitor in front of them and they can still get texts and they get those dopamine hits. And it's definitely an issue. It's a big concern. It worries me.
We need to create solutions by the teens themselves. You know, we as adults, what do we think? Okay, there needs to be a parental advisory. There needs to be a parental control. The social media platform has to ask your kid their age so it knows. At some point, why not use, for example, the Teen Line that we partner with, where you have incredible, I saw about 50 to 60 of them in our world premiere suicide prevention center the other night, getting trained in suicide prevention and live crisis care. They do shifts, these kids. One even told me she skips out on Friday nights, Saturday nights with her friends so she can save other youth lives. Wow. What if those kids had the money? If any listeners are out there, contact me at Didi Hirsch. I'm happy to work on it with you. What if those kids had the money to build the system that would keep other kids safe? They're already invested in it. They know better than I do how to handle these technologies. My 4-year-old understands my iPhone better than I do. So I'm not saying we'll enlist my 4-year-old, but I would pick a 14-year-old on any of these platforms more than some of the out-the-cockers, as my grandmother would say, in Congress to help solve this.
Absolutely. They understand Snapchat and TikTok way better than we do anyways.
Yes,
So
what if we wanted to block this, to prevent that, to encourage and inform young people in real time in a healthier, better way? There was a TikTok video of a young man that my CFO shared with me, and he just talked about the mental health pressures of parents always wanting their kids to succeed. I forget his name. Incredible. Within hours, I think he had millions of views. We were talking about adverse childhood experiences with one of the preeminent scholars and advocates, friend Nadine Burke-Harris. I think she took years to get to millions of views this on her video about ACEs, right? This kid, few minutes, had millions of followers and views. I mean, this is what this young generation knows how to do: reach each other, educate one another, partner and advocate together in the digital realm. We need to harvest that passion and that knowledge for them to be the ones who heal their own generation with our support and love and guidance. But it's not going to be on us to fully protect them. They have to be part of the solution.
I really appreciate your optimism. And I, like you, do feel hopeful. I started podcasting about 3 years ago before the pandemic. And now mental health is literally on everyone's mind. Everyone's talking about it. Celebrities, you turn on the news, it's constantly being discussed. People are talking about it, which is increasing discussion and hopefully getting rid of the shame and the stigma. And people are self-identifying and asking for help. What I say all the time is that asking for help is brave, and it's not just possible to get better, it's probable, and the earlier the better. And I love what you're doing. And I'm so grateful for Didi Hirsch. I ask all my guests this question. And of course, this is not a typical quote, Dear John letter. This is a love letter. And so if you could write your younger 20-year-old self a Dear John love letter, knowing what you know now, what would you have told yourself?
I would have said what we say to kids today. Know that you matter, that you are not alone. Keep going, because at the end of all of this is something wonderful where you are going to save and transform millions of lives. You're on the right track. Don't lose sight of what you want to achieve. It's there, and help is here today so you can get there. Just seek it out. Ask for it. Be brave to recognize the signs of something not right in your head and go get that help. Like you go get an A+ on a test, like you go do anything else in your life. You shouldn't be ashamed of it. You should be proud that you can achieve that healing so you can go and heal others.
Amazing. Last question. Do you have any happiness habits? What do you do that brings you joy?
I am blessed as a religious Jew. I go dark every Saturday from Friday night sundown to Saturday night when the stars are out. I am detached from the online digital world, no emails, no social media, no phone calls. And it is such a blessing to have that quiet 24 or so hours where I get to be present with myself in my head, with my children, my beautiful, incredible wife. It's such an incredible blessing to think about life and why are we here and why do we do these things and what does it all mean? I am grateful, so grateful for the beautiful 2 children my wife and God gave us, because the joy that I see in their eyes. Parents said to me the other day, I just want to tell you, when I go into the school, your children have that goodness, that loving kindness, and I see it unprompted, and I feel incredibly blessed to have these wonderful angels in my presence. And it's their grandparents, their great-grandparents, the history of the people before us who came led to them and our values that we try to transmit. And the greatest joy, just watching them reflect on everything from the rabbit. Why is there a rabbit over there on that vaping store, Dad? And I think to myself, do I shield them or do I tell them? Because I know they'll solve whatever we may fail to solve. They will solve it. They will say, enough. Their society will be healthier, whole, and more just than ours could ever dream of. And they give me joy just watching them be happy today, but think about the people, the incredible mensches, as we say. I know they'll grow to be tomorrow. So I'm very, very grateful for that. And it gives me such joy.
So happy for you to have that love. There's really nothing like it, honestly. Well, Dr. Goldfinger, thank you so much for this. It was so enlightening. I'm so grateful for all the work you are doing on behalf of so many families. And it's such important work. And if there's anything I can ever do to support you or Didi Hirsch, please let me know.
Thank you. Thank you for having me. And I'm grateful for you and what you do to share these stories, to get people inspired about what can be in our families, in our communities, in society. It takes people to actually talk about these things, to continue to talk about it. One of the things I think I've reflected on in joining DD Hirsch is that my predecessor in this organization for about 25 years had honored people who would talk about mental health, come out of the shadows, share their story, advocate. You know them as Carrie Fisher and Terry Bradshaw, but lately Kid Cudi and Selena Gomez, Congress member Jamie Raskin and his wife Sarah Bloom Raskin, Selena and them we honored last year. And a lot of it is about the interpersonal stigma, how we talk about it and make it okay. And then the next leg of the journey is really what I'm here to address, which is the structural stigma. It's more insidious. It's a system that's designed against those with mental health needs, substance use needs, suicide needs. That's not sexy healthcare financing discrimination. So we got to figure out how to frame it. But once you do, that's the end of the journey. Not 60%, including teens, struggling to get care, where we all say that they deserve it and we make it happen. I'm thankful to partner with you to get that message out there. And somewhere there'll be a listener, colleague, someone with a connection that will say, actually, he's right. She's right. let's do something about it.
Maybe we can get some big donors to help with that teen line. I'm very honored to be able to share your story and also inspire others to reach out for help. Well, thank you so much, Dr. Goldfinger. Take care. Bye. This is Rachel Steinman. For more information or to contact me with any questions, comments, or guest ideas, please check out rightnowrachel.com. That's right with a W. Thank you so much for listening, subscribing, and sharing, dear family. And if you found value in what you've just heard, I would love and so appreciate a great review on Apple Podcasts, Stitcher, or wherever you listen to your podcasts. Until next time, I wish you love, happiness, and good mental health.